I'd like to give a warm welcome again to our listeners and viewers and another in our series of interviews with the experts here at Mayo Clinic. I'm Malcolm Bell, your host for these sessions. And I'm joined once again by Dr. Jokhadar, who has joined us in the last two podcasts. So this is the third of a three-part series on management of patients with adults with a history of congenital heart disease. So, Maan, thanks again for joining us. And if this is an introduction that people are hearing for the first time, I would encourage them to go back and listen to the last two podcasts where we talked about caring for the hospitalized patient and also the patient in primary care. So today, maybe we'll just focus on some of the specific conditions that we see, and I'd like to hear your tips for the management of these patients. And again, this is really for whether we're a cardiologist or in primary care or internist, how to manage these patients when we see them. And we'll start off with the seemingly simple scenarios that we've talked about before. And let's start with a very common one, and maybe you can remind our listeners how common bicuspid aortic valve is. And then talk about the management of that valvular disease and the other disease process that often accompanies it.
Thank you, Dr. Bell. Bicuspid aortic valve is very common. About 1% of us are born with a bicuspid aortic valve. And the severity manifestations are highly variable, from manifesting with severe problems early in life to being completely asymptomatic, well into the eighth, ninth decade. So bicuspid aortic valve, we know, can increase the probability of both stenosis and or regurgitation. But the main thing to remember is there's also an aortopathy. There's also an increased risk of both aortic root, sinus of Valsalva, and ascending aorta dilation, which can be easily missed on routine transthoracic echo. So that's the main thing to remember as it applies to bicuspid aortic valve. You don't want to be blindsided by a growing ascending aorta aneurysm that could increase the probability of dissection and or rupture.
So it'd be important to look for that beyond sort of the I guess the general sort of echocardiography if you're not looking for that. Does that apply to the descending thoracic aorta or the abdominal aorta? Should we be looking for that as well?
Not so much for bicuspid aortic valve, but there are other aortopathies such as Marfan's and Ehlers-Danlos, et cetera, where that would be more important.
But if you do have the aortopathy with bicuspid valve, what you're saying is it would be very unusual to get aortopathy in the remainder, the descending aorta?
Unless there is something else going on, a concomitant aortopathy or something like this, usually ascending aorta. And now that's different than, say, coarctation. So there's an association between coarctation and bicuspid aortic valve.
Oh.
Only some people with bicuspid aortic valve have coarctation, but most people with coarctation have a bicuspid aortic valve. And the aortopathy in coarctation can be more problematic, particularly at the area of a coarctation repair site. Depending on the type of coarctation, there may be an increased risk for recoarctation, aneurysm, or pseudoaneurysm at the coarctation repair site. So knowing how that's repaired is important, not just for routine monitoring and long-term care, but also simple things like where to check a blood pressure. If someone, say, has had a subclavian flap operation for a coarctation, that means that the subclavian on the left typically has been sacrificed to enlarge the area of coarctation. And so the pulse and blood pressure in the left arm will be diminished. So these are common things that are seen all the time, and sometimes patients with coarctation can have aortopathy in other places and vasculopathy in other places, including an increased risk for barrianeurysms. So all patients with coarctation should ideally have just one-time screening for barrianeurysms in their lifetime as an adult, typically an MRA without contrast of the head, typically is all you need.
And then presumably for many of these, just getting back to the coarctation, there's going to be probably some follow-up imaging on a regular basis. But the blood pressure reminder is really important, because even if the coarctation has been fixed, the blood pressure may still be misleading in that left arm, depending on what was happening. And hopefully the patient's aware of that, and we'll remind them not to act on the blood pressure in the left arm. That's of course if they're able to tell you that. You can imagine a scenario that someone actually couldn't tell you that, and the next thing you think the patient's in shock. So that would be very, very different treatment. Let's go back.
It reminds me that there's a quick vignette that I think is very informative. We had a patient many years ago who had a recoarctation, and we were getting ready for him to have surgery, but he got influenza. He didn't get his flu shot, and he got influenza pneumonia, ended up in the ICU in his local hospital. They were checking the blood pressure in his right arm, but the blood pressure in his legs was very low. And so he ended up getting life-threatening kidney injury and kidney failure, because the perfusion to his kidneys was suboptimal, just monitoring the blood pressure. And so it would have been ideal to check blood pressure in the lower extremities as well.
My goodness. Well, that gets back to our first discussion in the part one of our series, is in terms of consulting with adequate congenital heart disease specialists, particularly in that ICU setting. So let's get back to the aortic valve, and what's the chance that if someone has a bicuspid aortic valve, you're seeing someone again, maybe good primary care or internal medicine, and they've got known aortic valve, bicuspid aortic valve, seem to be doing fine. But they may ask you, well, what's the chance that I'm going to need a valve replacement? So maybe just talk about what is more prevalent: stenosis, regurgitation, mixed, and what is the likelihood that ultimately at some point they're going to require aortic valve intervention, which may not necessarily be surgical intervention as we know today. But
I think it depends on their age. It depends on other concomitant issues. It's highly variable. And there was a recent paper that I saw that I think about 70 to 80% will need an aortic valve replacement in their lifetime. But I think there's referral bias in that particular paper, and it may be closer to 50%. So I think we don't know for sure. It's highly variable. The main message is that many patients will need something done, whether to the aortic valve and or their aorta, and they will need routine follow-up. The good news is, based on a population study out of Canada, out of Toronto, the survival for patients with bicuspid aortic valve is comparable to the survival in the general population. So I think that's a very reassuring message.
Yeah, and speaking of vignettes, I recall seeing some of these cases and actually hearing some of these cases presented where someone presented with STEMI, and we're so quick to get someone to the cath lab, to get that artery open. That door to balloon time sort of drives everything. But in fact, they had a history of bicuspid aortic valve, and in the rush to get someone to the cath lab, they didn't appreciate the fact that actually this was actually an aortic dissection, from their aortopathy, and of course that could be really disastrous. So again, there's some complexity there and things to keep in mind. And so let's move on. We're talking about valves, and we're not going to talk about whether it's TAVI or open surgical valve replacement. That's another discussion. But many of these patients, young and older adults, have had mechanical valves. Well, they have conduits, and we won't have time to go into all the different conduits and the implications there. But over time, there's degeneration of these valves. There's, we know about risk of endocarditis, and many of them are anticoagulated. So maybe, again, just perhaps to summarize for us, what are the things that we should be looking out for in these patients? And particularly, as I said, just focused on the ones who've had mechanical valves and conduits or other hardware that's present.
I think you know, most of these mechanical valves are durable for many years, but we're recognizing that there's an increased risk of pannus formation on these valves for a long time. So an echo every few years is probably reasonable, provided there's no clinical change. A good auscultation is very important, listening for the clicks. And I'll have to say clicks because most of these bileaflet valves have two leaflets, and sometimes one can be fooled when they hear a crisp sound when only one leaflet is moving. And I've been fooled by that in the past. So having a very low threshold for further evaluation, whether it's echo, a fluoroscopy of the valve, or cardiac CT, to if there's any change in the gradient or change in the physical exam or physical manifestations of the patient. You have to make sure that these patients are the guidelines for adults. All valves, whether tissue or mechanical, should be on aspirin. In addition, and if they're mechanical, in addition to that, you would need to be on anticoagulation with warfarin. And the cutoffs for anticoagulation, whether it's 2 to 3 or 2.5 to 3.5, are something that we can go into. But those guidelines are pretty clear in terms of what the cutoffs are for appropriate anticoagulation. The other thing to keep in mind is when to bridge and when not to bridge for other procedures. That's also critically important to keep in
Just
mind.
before you go on that, because this is going to be really important. So this was going to be my other question, and maybe the background here is that we've moved in the non-adult congenital heart disease population of our patients with atrial fibrillation and some valves away from bridging just for certain procedures, and there are obviously some high-risk patients. So that's just as a background, and as your patient population is obviously much higher risk. So tell us what the current recommendations are and how you manage that with these patients in terms of bridging.
So much to keep in mind, and some of it is in the guidelines and some of it is not. I think the number one question is whether anticoagulation needs to be stopped at all. For most dental procedures, anticoagulation does not need to be stopped. And sometimes it's a conversation. I've been surprised, with the types of operations that some of my colleagues are willing to perform without interrupting anticoagulation. So the first question is, does anticoagulation even need to be interrupted? And oftentimes it does not. The second question is, what type of valve is it? Is it one of our newer generation valves with a low thrombotic risk versus an older generation valve with a higher thrombotic risk? Where is the location? Mechanical aortic versus mechanical mitral or tricuspid or even pulmonary? The aortic is probably the least risk. And then what is the bleeding risk of the procedure involved? And it's all about balancing the risks and benefits of stopping anticoagulation. And a lot of the time, we end up interrupting anticoagulation using Lovenox or low molecular weight heparin, when in fact they may actually increase the risk of thrombotic events and increase the risk of bleeding. So it requires being very thoughtful and often individualizing the risks and benefits in these patients, and oftentimes a conversation with the proceduralist who will be performing the procedure or the operation.
Yeah, you make a very good point about the low molecular weight heparin, and certainly outside of this population, it's certainly been my impression over many, many years that the drug that causes the most bleeding in the hospital is not warfarin, it's not a DOAC, it's not aspirin, it's not Plavix, it's heparin. And once you get into that terrible cycle of bleeding and then having to stop, and that becomes a problem when you've got a real need for prophylactic anticoagulation. And I think the point you're making is you don't want people to come off anticoagulation for too long, and if it's appropriate, then yes. But if not, maybe we don't have to do that, or we could, certainly we don't have to bridge everyone. I think that's what I'm hearing you say.
That's right, and sometimes your risk of bleeding on therapeutic warfarin is less than the risk of bleeding on while being bridged with low molecular weight heparin.
Yeah, no, absolutely. Well, we've just got like a minute left here, Man, and maybe just a quick word on endocarditis prophylaxis. Who needs it, and how is it given?
So thankfully, the guidelines are very clear as to who needs it and who doesn't. Anyone with an artificial valve or artificial tissue. So that's easy. Anyone with a prior history of endocarditis. Anyone with a residual shunt. So not, for example, not a VSD, but a residual VSD. And anyone who's cyanotic. Those are, and then the last, which is less common, is transplanted patients with valvulopathy, which is an unusual circumstance. But if you look at the guidelines, that would be my recollection of the only populations. So, for example, bicuspid valve is no longer recommended. Mitral prolapse, which was used to be in the old days, no longer recommended. Now, they are at increased risk of endocarditis, but taking the antibiotic only increases the risk of Clostridium difficile and other complications, and does not actually reduce the risk of endocarditis.
Okay, well, again, that's a really good point. I think the other point that we should take note of is, as you said, it's not just having someone with a mechanical valve or a prosthetic valve that we're concerned about. It could be someone who's got a residual shunt, and to the provider is not used to looking after these patients, that may not immediately cross your mind that there's someone who may need prophylaxis there. So, Maan, this has been an absolute pleasure having you spend all this time with us over these last 3 parts of a series of managing patients with adult congenital heart disease. I really want to thank you for that. I know you have a lot of other talents. I look forward to having you maybe discussing this further, or something else that is of an interest to viewers. So really appreciate you sharing your knowledge and recommendations with us.
Thank you, Dr. Bell.
And with that, we'll wrap this up. And again, thank you for to all of you viewers and listeners for joining us, and look forward to having you join us in other series and episodes of interviews with the experts. Thank you.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Benjamin Hibbert, Chair of the Division of Critical Care Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for you and your patients. Head to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.